All right, we're going to get started. So this is the expert panel Sequela of RYR1 related diseases. I'm honored to be joined today by some of the world's leading experts in neuromuscular diseases, including RYR-1-RD, for this important panel discussion on the sequela of RYR1 related diseases. In my role as patient liaison for the RYR1 Foundation, I regularly speak with individuals and families affected by this disease. Many of the questions I hear go beyond the primary symptoms, focusing on additional challenges and related issues that often emerge. These conversations have helped shape the focus of today's panel. I'm incredibly grateful to have Dr. Karsten Bonneman, Dr. Payam Hassel, and Dr. Nicole Vermans here to share their insights and expertise. Thank you all for being part of this important discussion. So the first one that I'm going to address is osteoporosis and bone health. What is known about the prevalence of low bone density or osteoporosis in individuals with RYR1 related diseases, and are there specific risk factors or mechanisms in this disease that may contribute to decreased bone strength or increased fracture risk? Yes. No, it should move over.
Well, as far as I know, no studies have been performed on RYR1 related diseases in particular, but gradually more attention is arising for bone health in neuromuscular conditions in general. And during the research workshop, there was a presentation about physical therapy and the importance of standing upright. Standing and walking is a main driver for growth of bone cells. So you could argue or expect actually that if a patient with any neuromuscular condition is limited in walking and standing for a long time, bone health will become impaired. To raise awareness for bone health in neuromuscular conditions in general, we organized an international workshop last year. It's called ENMC in Europe, where different experts came together. And one of the main persons in that group was Erin Ward. She's a pediatric endocrinologist in Toronto and an expert in bone health in Duchenne muscular dystrophy. And she really helped our field to write recommendations for the assessment and treatment of bone health in patients with various neuromuscular conditions. And then coming back to RYR1 related myopathies, in our natural history study, we're now assessing bone health in patients with RYR1 related myopathy. So in a number of years, we have these data available. And after the ENMC workshop, I started assessing this in my clinic as well. And then besides a lack of standing and walking, there's of course nutrition. And what you need to build bone is calcium. And calcium is available in many nutrients, including dairy products. I don't know what's in the lunch box today, but make sure that you have your calcium. Another thing is vitamin D, and that's what you would need if you're at a conference here, because we don't go outside in the sun. Vitamin D is a vitamin which is produced by the skin. And when you live in the country where your ancestors are from, your skin is most likely adapted to the intensity of sunshine in that region. But I discussed with Payam, for example, that living in the United States is not the intensity of sun which is made for his skin color. So then you should use vitamin D as well. And for women above the age of 50 and men above the age of 70 as well. But if in you reduced bone health is detected, your clinician will most likely recommend you to start using vitamin D and calcium at an earlier age.
Dr. Mahassel and Dr. Bonneman, do you want to remark on any more on that? Okay.
The only thing I was going to add is I've had some of my patients ask me about calcium and bone health because they're concerned because RYR1, as we discussed, is a calcium channel and regulates calcium. So it's a relatively simple explanation that the calcium that we're talking in the muscle is different from the calcium that's in the bone, and RYR1 is not really known to play any role in the bone tissue itself. So the issues are related to the muscle and bone interaction, not a direct calcium effect in the bone.
Okay.
And to add to that, also your nutritional calcium does not mess up the calcium in muscle either. So when we talk about the leaky ryanodine receptor and then too high of a steady state calcium in the muscle that would do damage, your nutritional calcium is completely different and differently regulated, so that's not going to mess it up or improve it for that matter. So it's safe to focus on the bones with the nutritional aspects of it. It is, whenever you move less, bone density goes down, and even that happens even prenatally. We had some testimony yesterday of a little baby who was diagnosed with osteogenesis imperfecta because of fractures after birth, because of low bone density, and that, of course, is a result of lack of or less prenatal movement even. So it's always an issue over the entire lifetime. The last thing I'd say, and that comes also from general recommendations from the Toronto group and the neuromuscular groups in general, is the use of bisphosphonates, which is a medication to increase bone density that is used in extreme osteoporosis, is only indicated in neuromuscular disease when there are fractures, unprovoked fractures that are painful. So not outside of that. I think nutritional management is the way to go, and activity, standing, gravity, movement.
Okay, the next category is insulin resistance. Are individuals with RYR1 related diseases more susceptible to insulin intolerance, and why?
For me? I think you can take it easy. Yeah, you. Payam is going to start, because we just learned about it in the research workshop.
Yeah, so this is an area that we're learning more about. So we did have a very nice talk in the research workshop about how muscle, in addition to the role that it plays in movement and generating movement, is also essentially interacts with the endocrine organs, and it's a major regulator of glucose in the body. There is some emerging evidence from some large patient studies, at least patients with the malignant hyperthermia susceptibility mutations or variants, and when you look at their glucose levels, that they tend to have higher glucose levels at younger ages, so they have impaired glucose tolerance, and there may be some clear biological reasons for that. But it's a moving target. So from a practical standpoint, the general guidelines for adults in the United States is to get yearly screening for diabetes and impaired glucose tolerance through your primary doctors, regardless of whether you have RYR1 or not. And I think that's probably sufficient to screen for abnormalities in glucose metabolism in individuals, and if it's there, it would get treated in a standard way until we have something more specific.
You want to say anything? No. Okay.
So I can add from a pediatric perspective. So there is, in many congenital muscle diseases, best studied probably in the form of congenital muscular dystrophy, when you have very low muscle mass from birth, and your liver isn't quite mature yet to provide glycogen, children can be more prone to what we call ketotic hypoglycemia, drop in blood sugar after longer fasting or after activity. So that is because the muscle can kick in to make glucose when the liver runs out of glycogen stores, so the reservoir of glucose to provide to the bloodstream. If your muscle mass is very low, then there's less amino acids from the muscle available for the body to make sugar from. And so you can get into that dip of having not enough sugar production, which can lead to hypoglycemia. Sometimes, we haven't seen it yet in congenital RYR1, but in other congenital disease to a degree that they are waking up with very, very low blood sugars, even with loss of consciousness and seizures. So the treatment of that, of course, is very simple: to provide nutrition that provides enough glucose stores even late in the night, and sometimes it requires even overnight feedings in the extreme cases. There's, some individual susceptibility to that. Some even not muscle-affected children have it spontaneously. Usually, one matures out of that as the liver goes more mature and with better glycogen stores. It can take a longer time in children with congenital muscle disease.
Thank you. Next are gastrointestinal issues. What are the most common GI issues seen in individuals with RYR-1-RD? Example, constipation, diarrhea, reflux, swallowing difficulties.
I think this has not been assessed either, so I cannot tell which is most frequent, but all symptoms which were mentioned by you do occur. Dysphagia most likely is often seen in early age.
Exactly, and the good news is there from the large retrospective study that Francesco Montoni's group and Anna Sarkozy in London did, is that there is a fair number of children who need a G-tube early in life, but then grow out of it. So they do develop oromotor strengths and abilities that allows the G-tube to be kind of decommissioned, if you will, kind of closed for a while and then eventually grow out of it. So there, even if there's early dysphagia and swallowing troubles, it doesn't mean it can't get better over time.
And once it gets better, there's no guarantee that it will remain perfect throughout life. So we do see some elder people for whose swallowing becomes a bit more difficult and for whom it is very time-consuming to get sufficient nutritional intake through swallowing themselves, so they sometimes have a tube for additional feeding overnight.
Yeah, that's a good point. So coming back to my previous point about the hypoglycemia, having G-tube access is, of course, the rescue, because then you can just give something overnight and don't bother the child. So it's a good safety valve, if you will, to have for many reasons.
How about irritable bowel disease? Do you see a lot of that in the community?
So, I think in general with neuromuscular weakness, and especially if you have reduced mobility, that can certainly predispose to developing constipation. I have patients with RYR1 disease who also have the other problem. And so it's something that it's definitely anecdotally seen, but it's not like that every person is going to experience it. So it's an individual case-by-case basis. But constipation in immobility is common, and it sometimes requires regular use of laxatives, like Miralax or something like that.
And especially if it's immobility in combination with swallowing difficulties, which keeps a child from swallowing a lot of fibers, I think, or chewing and swallowing a lot of fibers, and then you have a lack of fibers and a lack of mobility. Sometimes challenges using the toilet, drinking less, so it's usually an add-on of different factors. That's where your nursing knowledge comes in too, I think.
Yes, it's true. I mean, that all adds up. Okay, next, statin intolerance. This is a big one. So statin-associated muscle symptoms are common in the general population, but are individuals with RYR1-RD more susceptible to adverse effects from statins? And for those who require lipid-lowering therapy, are there alternative options that may be safer or better tolerated?
So statin drugs are commonly used to reduce cholesterol and reduce a risk factor for cardiovascular disease. There are definitely some anecdotal reports of a statin-induced muscle toxicity in individuals who either are carriers of RYR1 variants or have RYR1-related mutations. But it's not something that's universal. Clearly, when you have a muscle disease, you don't want to add insult to the injury and make things worse. So my practical approach is if one of my patients needs to take a statin drug, we do a close monitoring. So we check the CK levels beforehand. They start on the statin at the low dose. We recheck it, we monitor the values closely, maybe a little bit more closely than the average individuals, look at the symptoms. If they're doing fine, it's totally safe to continue with the statin drugs. there's no reason to go off. If you see the CK levels go up or they develop symptoms of muscle pain or weakness, then obviously they go off of it. There are alternative drugs. There's an injectable cholesterol-lowering drugs that works completely different from statins available by the brand name of Repatha here. And some individuals need to use that medication because of statin intolerance and their high risk factor for cardiovascular disease.
And that's fully in line with the way we approach it and the recommendations for persons with neuromuscular conditions overall in statins. Start low and go slow. And I was wondering whether any of the young scientists from the lab of Andy Marks want to add anything on that? Are they still here?
I don't know.
No.
I also was thinking of Dr. Riazi. I don't know if she's in the room right now. If she wants to add anything to that. Okay. Oh. Do you want to add anything?
Thank you. I agree with Payam. We don't have a lot of, we have about 4,500 patients with RYR1 in our database. Again, different mutations. And probably 5 of them, they have statin intolerance. So I haven't seen a huge statin intolerance in our population, but again, Karsten, Nicole, and Payam's experience might be different.
Okay, thank you. Next is muscle tearing and ligament injuries. Are individuals with RYR1 related diseases, specifically MHS, so malignant hyperthermia susceptible phenotype, at increased risk for muscle tears or ligament injuries? And if it were to occur, are there any unique considerations for recovery in someone with an RYR-1-RD?
Well, we're looking at each other because we really don't know the answer, I think. Minal might want to help or help us or comment on it. I think overall, problems with the tendons do occur in patients with neuromuscular conditions, and there again, it's about start low and go slow in training, more start lower and go slower than people without neuromuscular conditions, but it's not there's a specific strong association between the two of them. Minal, do you want to add anything on that?
So far, we don't have any research related to RYR1 and muscle repair, but as Dr. Vorman said, that it is your rehab would be much slower than a typical person. So just have to monitor it closely and work with your orthopedist and your physical therapist in terms of advancing as you improve to the next step. So not much to say.
Okay.
And I think that's also important when you go home after this meeting, you've become very inspired to start doing physical activity or sports. Start low, go slow, find someone to recommend the intensity of your training. It's not that, I think you can reach a lot, but you have to do it a bit more careful.
But can I just ask a question? If you have low muscle tone and you don't have great strength to begin with, and then as you age, like I'm 62, so I am obviously weaker than I was with CCD at 62 than I was at 30. So it's been explained to me that my tendons are impacted and getting a lot more use and are a lot more damaged because the rest of my muscles aren't making up for what they should. Like my glutes are gone, you know, I don't have good quads, so like I'm overcompensating and my tendons are getting overused. So would you say that it's at least fair to say that even if they're not directly impacted, they're impacted by a loss of muscle tone and the fact that I don't exercise?
Well, I think, but that's not specific for this genetic cause of a neuromuscular condition. So overall, I think yes, but that's again,
Yeah,
I would like to comment on that, but it's not specific for RYR1. Maybe Karsten wants to comment on that?
I mean, what I would say, I completely agree with you that because of the pattern of weakness that RYR1 tends to affect muscles, and some of them are less affected than other muscles, individuals tend to overuse the ones that are working, and that predisposes to additional injury in those otherwise well-functioning muscles. And so I think that is, again, not specific to RYR1, but it's part of the compensation for the weakness in the other muscles. But I do think that the solution is not necessarily avoiding activity.
Right.
The solution is to have a measured activity and exercise that works for you.
I was going to jump on that. Yes, the solution is not to stop all exercise, but to find a form of exercise that is less impactful, swimming, biking, not biking, but just recumbent biking, but things that you're not as much weight bearing, which also contradicts with what we were talking about in terms of osteoporosis and bone health. So you have to find the right balance. So you can do light resistive training, and that will help with bone health. But in terms of swimming is a really good exercise for that. So.
Yeah, exactly. I wanted to support that. It's actually interesting if you exercise muscles that you're not necessarily using, that actually helps the muscles that you're using more as well. There's kind of, if you improve your aerobic metabolism by this type of exercise in water, for instance, that is kind of building mitochondria, if you will. It is happening across all muscles, even in the muscles that you're using not preferentially in that type of exercise. So it's a very interesting phenomenon that any type of exercise in this aerobic realm without with that's concentric and endurance based will help all muscles in the body, even the ones that you're not necessarily exercising at that point. The other point that you make is a very important one, and I tried to make it this morning as well, is there is some progression of any quote-unquote static muscle disease in you and my age group. And that is a process of age-related sarcopenia that happens in everyone. There's an age-related kind of muscle-giving way to atrophy to some degree, which we are all told to counteract early on, and I'm lazy and I don't do it enough. But that is amplified in any muscle disease. And give that, in addition to that, the muscle is less good at regenerating. The reserve cell population, the satellite cells is less active. And so you do experience that, and not only in RYR1, but in many muscle diseases that go slowly over the ages. Once you hit 40s, 50s, you start noticing that there's some more give away of the muscle.
Okay. Next is prolonged bleeding issues. Is there a connection between RYR1 variants and coagulation issues? Has there been any studies? I know that there is in terms of gynecologic, but we're just talking in general first. And RD, I don't know if you're in the room, you might want to talk about the gynecologic after we address this one.
So the only study I know is by Dr. Jungbluth's group that was recently published, actually, where they surveyed individuals with RYR1 variants and looked at anecdotally in their history about bleeding, and it does show that there seems to be a correlation between, especially the individuals with malignant hyperthermia susceptibility variants and prolonged bleeding times. Where that's coming from, whether it's not clear. So it's not clear it's related to, for example, platelet dysfunction or coagulation factors or others. So we still need to learn more about the underlying cause and the connection.
But is Artie still here? Artie is around, but not in the room now. She will most likely come back this afternoon. Artie Mystery is a postdoc researcher in the group of Heinz Jungbluth, and her PhD was on this. And we did not find coagulation abnormalities, but there's a reduced function of smooth muscle cells in the walls of blood vessels, which most likely cause the prolonged bleeding.
She's going to be doing a talk tomorrow on this, so it's in the agenda if you have interest in attending that. All right. I don't have any more questions on my end. I would like to open it up to see if anyone in the audience has any further questions. yeah, I'm going to have Jackie go, and then you can go next.
Hi. Since we were covered the topic of osteoporosis, I have gotten some mixed advice. We had an endocrinologist change, a pediatric endocrinologist change, and my daughter did have a humerus fracture, and so is on bisphosphonates, on zoledronic acid infusions. And we do certainly maintain giving her vitamin D daily. But we had been told by our last endocrinologist that there wasn't a lot of research in the pediatric population with having them on supplemental calcium, and there being potentially a risk over time, I believe, with like hypercoagulability. So like the opposite of what you're saying, there potentially being cardiac risk with having high doses of calcium over, say, if you're starting calcium at 7 years old. So they were suggesting that we just did calcium from a dietary perspective and tried to focus on her leafy greens and her dairies and the things that we've talked about, which we certainly do, but she doesn't eat a ton. And now we have a new endocrinologist that we've sat down with and has suggested that we restart calcium and that we do calcium. So would you suggest that I get is there a way to get lab values? We do get lab values of calcium. Is that decision something that can be made on some sort of objective advice, or?
I don't know how reliable the lab values are going to be, but in terms of nutritional, if you have enough vitamin D, then typically nutritional calcium at good calcium intake is sufficient to replenish the bones, and so it doesn't need pharmacological doses of calcium on top of that. But I will say, though, with the bisphosphonates, and that's something maybe to bring back to your endocrinologist, yes, they're good at healing these fractures, but what they also do, they change the bone structure somewhat in chronic use. And if you're still kind of considering scoliosis surgery at a later stage, something to consider, because it changes the bone the surgeon will encounter in the scoliosis surgery. And some scoliosis surgeons say it gets more difficult to drill and the bone is different in composition. So maybe something to put into the equation as well.
Thank you.
I mentioned the ENMC workshop. That report has been published, but it's an expert opinion because no research, hardly any research has been done. I can send you the review we did on congenital myopathies and bone strength. And we have encouraged Leanne Ward, together with the other pediatric endocrinologists from the United States, to also write a narrative review as an expert opinion review with all the different recommendations in there. And that has been submitted and will be published later this year.
Oh, that would be great. Yes. Okay.
Okay, Mandy.
Yes, hi. Do you see many patients with the RYR1 myopathy have trouble gaining weight? If so, how do you manage this?
Gaining weight?
Gaining weight, yes.
In children?
Yes.
Yes, so that it's always different from individual to individual, but if you have kind of lean individuals, kind of there's a certain leanness in the family and they don't tend to gain much weight anyways, then yes, you see that. And that is part of the muscle having lower volume, so and the muscle isn't as good to put on additional muscle mass. And so it would be wrong to try to kind of push the growth percentiles into the normal range just because it looks better. What you want to see is that there's no plateau and no loss of weight, but to allow for the individual weight percentiles of the child. What actually is worse than that is if you have so much fat, not muscle, that it becomes actually more difficult for the child. There's data from other neuromuscular diseases. If your body weight composition really switches towards a high fat content of the body, the neuromuscular disease itself actually can be less good. I mean, there's an outcome that's different. So the quote-unquote heavier set patients with neuromuscular disease do worse often.
Thank you.
Well, and if this patient Karsten was describing is growing into adulthood, we will remain seeing a person with a BMI of about 15 to 16. And what I talk about is also remain on the same weight, go and talk to a dietitian to make sure that your intake is sufficient. And I don't expect someone to go up to 20 because that will not happen.
Well, when you say talk to a dietitian, we're having a hard time finding a dietitian who understands muscle diseases. There seems to be a dietitian for endocrinology, there seems to be dietitians for GI, but overall in the scope of helping support growing the muscle and what foods or nutritional things you could take to help with that, I don't know if you have any guidance there of maybe doctors or specialists that could help in a nutritional aspect?
I do, but they're not in the right region, so I'm going to handle.
Yeah, I mean, it really, I don't know which center you follow that, but often if you find a MDA clinic, for instance, with the whole team, the nutritionist will be very attuned to this and find the composition of nutrition and also of projected caloric intake and desired growth curve that fits a child with neuromuscular disease. You're right. I mean, it is important to have the underlying disease in mind and not chase numbers and percentiles.
Yeah. Thank you so much. I have one more question. Do you see patients with RYR1 variants that have increased metabolic temperatures without infections?
The quick answer is I don't know, right? So, we have normal ranges for temperature, but that's a relatively broad range. Scientifically, it makes sense that some individuals with certain RYR1 variants would run as a little higher than they would have if they didn't have it, but we don't flag it as abnormal until it reaches a certain threshold for fever, right? So it's something that needs to be systematically studied in a lot of individuals with RYR1 variants and a good control group to see whether that pans out. But it makes sense. Anecdotally, I've been told that. It's a really good point,
yes.
But
We have to put that on our to-do list to research that. So how many folks have experienced excessive heat sensitivity with, yeah. All right, look at that. Yeah.
Next study, huh? Okay.
Yeah, actually, I have two very different questions. The first one's a quickie. So you had mentioned earlier about Repatha and other injectable alternatives to statins. I mean, it is a challenge to get the approval for the injectables. They tend to be kind of expensive. Insurance companies tend to reject them the first time around. So I wonder what your thoughts were about things like Zetia, maybe an old one like cholestyramine, these sort of non-statin ones that are actually already generic, already in pill form.
So, I think it all comes down to how aggressively do you need to control your cholesterol based on your risk, cardiovascular risk. So Zetia works, but it's not as effective as those other alternatives, the statins and Repatha or medications like that. And also cholestyramine has some additional side effects. It's not necessarily wrong to use those, but they often don't do the job, or they don't do the job well enough. So Repatha is a good option for somebody that really needs to aggressively bring down their cholesterol levels because, say, they've had a heart attack and they really need to control that when the statins are not tolerated or cause problems. I wouldn't necessarily jump to Repatha, and I gotta say, in individuals who have clear intolerance of statins that's documented, insurance almost always covers it eventually. It may take a couple of tries, but...
They usually reject the first time and then you got to appeal, because they don't really understand why you can't do that, because you have to explain it to them, basically.
Yeah, I mean, I think if you have documentation in the medical records that this individual tried statins, had side effects, I've never had a problem, a cardiologist telling me that they're not covering it. Eventually they will. But yeah, it does require a communication with them, unfortunately. Yeah.
Okay, and my second question is just, I mean, I'm a clinical social worker, so certainly with people who have some kind of chronic disease, you see a lot of, potential for anxiety, depression, certainly secondary to the condition. But I was wondering if there's any research looking at some kind of genetic biochemical component that might explain anxiety or other mental health issues in people that have RYR1 conditions.
Well, not any biochemical or genetic predispositions for this. It's the anesthesiologist in my center that says he can predict whether or not someone has a malignant hyperthermia susceptibility variant based on the response he gets when he's explaining what an in vitro contracture test means, because he sees more anxiety in the people who are susceptible. That's very anecdotal. I don't know whether Sheila wants to comment on that, if she's still in the room. She's not. We have done one questionnaire on various aspects of psychosocial functioning in patients with a RYR-1 related disease, both in patients with a myopathy and with the intermittent or dynamic phenotypes. And we did see a little bit higher prevalence of anxiety in the RYR-1 related disorders compared to the general population, but we never investigated whether there was any biochemical or genetic predisposition for that. I don't know whether you have any comment from the pediatric side? No.
Okay.
I think often there is a lack of support in this way, and that's why I think care in muscular dystrophy centers is so important, where you have a multidisciplinary approach to children and adults with a neuromuscular condition. And not knowing what is happening in your body is in itself already a reason for anxiety. And I think that's a thing we're currently treating in this session or in this conference, trying to offer people knowledge, understanding, insight, a network which will help them understand what is going on with their body, what it is, what kind of rare disorder they have, so they can get more grip or control, which is one step in a direction of treatment. But that's your profession then. Maybe you want to comment on that?
Again, I think you're saying really what kind of often is happening, which is that, the breeding ground of anxiety is lack of control. If you can't predict what's happening, if you can't control situations, if you have to constantly wonder if where you're going is going to have, good cutouts, ramps that are ADA compliant, they're not like, 20-degree angles, and just going to a new place and not knowing what it's going to be like, is not something the average person necessarily has to worry about, but someone with any kind of, condition that affects, the way your muscles work or the way your body functions, yes, it's going to be a big issue. And yes, I think it does, in and of itself, generate a lot of anxiety. And of course, having to deal with, I don't know about the future, I don't know about the unknown. So they can drive a lot of, mood disorder problems. I was just kind of wondering, aside from that, the usual situation with someone who has a unpredictable condition of some kind or health condition, I was just wondering if there was additional sort of biochemical, components to this. But you're saying either there isn't or there haven't been any studies to even look at that.
That's exactly as it is. And overall, I think there's gradually becoming more awareness of the great importance of psychosocial support. And support already sounds as if something is lacking. You can also refer to it as coaching or mental strength training. You train your muscles in physical therapy, but you can also train your thoughts with psychosocial support. And also, I've already referred to ENMC, but last year there was also an ENMC workshop talking about what the high need of psychosocial support for neuromuscular conditions. And we're now going to assess in my center, for example, what is the need of psychosocial support among the group of patients with another neuromuscular condition by interviewing patients, having focus groups, and that as a starting point to improve the care.
Right, and I think we actually have a presentation either this
Yes,
afternoon
that's
or
happening actually right now.
right now.
Yes. So
Sorry,
we're trying to get
we
back
should-
on time here. So I know that there's a few people that have questions. I'm gonna have to cut it off. I'm really sorry, but you can pull them aside during a break or in a little bit. We really need to stay on time. So I apologize about that. And then we're gonna introduce our next speaker now. Thank you.
Hi, everyone. We are now joined by Dr. Julie Bodman, and a licensed clinical psychologist and co-owner of Resilient Minds Behavioral Health, with extensive experience treating individuals facing anxiety, depression, and life transitions. Dr. Bodman has a special passion for supporting women through the challenges of motherhood. She's committed to promoting mental wellness through practical tools like self-care, boundary setting, and stress management. And we are honored to have her here with us at the family conference to help us better understand the emotional and psychological side of living with or caring for someone with a rare disease.
Thank you, Lena. Can you all hear me okay? Okay. I have to admit, speaking of anxiety, I got a little anxious when I walked into this room, and Lena told me that there are people here from across the entire world. So this might be my first international audience, so bear with me if I seem a little nervous or a little anxious as I talk to all of you about emotional well-being, psychology, and the impacts of living with or loving somebody with RYR-1 related diseases. Thanks again to Lena. As she said, my name is Dr. Julie Bowden. I'm a licensed clinical psychologist, and my main day job is that I co-own a private group practice based here in Pittsburgh in the South Hills area. In plain speak, I'm a therapist. I have lots of individual clients that I work with on a weekly basis, and that's what I do with the majority of my time. But I've been fortunate enough over more recent years to start getting these speaking gigs. And when I say I'm fortunate, it's not that I love speaking in front of a ton of people, but I love teaching. And I really like to talk to people about the impact that our emotional and psychological health has on various aspects of our life, our world. So I'm thrilled to be here today. Thanks for having me. In a few minutes, we are going to break out into groups, and we're going to talk about some of the things that I'm going to address with you all just now together. But before we start, I'm going to talk a little bit about how RYR1 can affect individuals emotionally, psychologically, socially, and educationally, as well as in terms of your day-to-day living. So we all know the physical impact that this disease has on individuals who are affected. As you can imagine, and as I believe was just being discussed right before I was brought on, there is an enormous psychological component that exists when you are living with a chronic disease. Anybody have, the big group, so you can feel free to raise hands, anybody have something that pops right into their head immediately about the psychological impact of this disease? Anybody want to shout something out for me before I keep talking to you? Awesome. Self-esteem, 100%. Love it. Keep it coming. Go ahead. Absolutely. Absolutely. How do we communicate to our children, our young children, about the disorder? And the anxiety that comes from having to communicate to our young children about the disorder. Great. Anybody else? Body image. Going to talk about that. Absolutely. Yes. I'm sorry? Guilt. Yes, it's on my list. Absolutely. Guilt. Loneliness. You guys are throwing out some really good adjectives to me. Keep them coming. Representation, being othered, being different, looking different, feeling different, acting different. Absolutely. What about basic? Let's go back to like the bare bones of what I do on a daily and a weekly basis as a psychologist. What about the basic depression and anxiety? Is there depression and anxiety that can come as you are living with or loving somebody who has this disease? Absolutely. I believe so. I believe so. And so, absolutely, I appreciate you all throwing some things out. So, in terms of psychological impact or emotional challenges, what I have listed, number one is chronic stress and anxiety. Due to the progressive nature of this disease and the many unknowns that lie ahead, physical limitations, multiple medical procedures, appointments, all of these things are incredibly anxiety-provoking. I almost feel silly throwing that out as the number one because it's so obvious. So a lot of folks that are living with or loving individuals who are affected by RYR1-related disease are experiencing or do experience a great deal of anxiety, and understandably so. Understandably so. Depression is, of course, the second one, particularly when tasks are hard, as one sees their disease or their loved one's disease progressing, or just feels as if there are more limitations. That can be very sad, that can be very depressing, and can lead to more than just, a day or two of sad mood, but sometimes more chronic depression. We talked about guilt, 100%. For those who are parents to affected individuals who may or may not carry the gene themselves, guilt that they have a child who is affected, guilt that perhaps amongst your community members, you are progressing more slowly or doing proverbially better than other individuals that you know. Frustration, grief. Everybody seems to think that grief is just related to the death of a loved one. What kind of grief do we experience when we are living with this disease? What are we grieving? Anybody comfortable sharing? What life would have been if things were different or if things were normal. The loss potentially of independence. The loss of mobility. Loss is not just the actual death of an individual, but oftentimes there is grief that comes in chronic illness, and absolutely with RYR1 for sure. Identity and self-perception challenges. So somebody threw out a few minutes ago self-esteem issues, body image issues, particularly if you are using a visible mobility aid. If you are a younger individual, but you are in a wheelchair, for example, feeling different, feeling other. These are all psychological and emotional impacts that this disease has on affected individuals. Briefly, I will talk about social impact. Understandably, there are family and relationship challenges, and one of our breakout groups is going to be for spouses of affected individuals and loved ones of affected individuals. So parental stress. So if you're the parent of a child living with an RYR1-related disease, parental stress and caregiver burden. I was lucky enough to speak several months ago to a conference of individuals, all of whom had special needs children. And what I spoke about was caregiver fatigue and the burden of loving and taking care of somebody who you want to do everything for, but it's exhausting. So the physical needs of the individual that you're caring for can cause emotional strain and financial strain. And I think that's something that not everybody addresses. Siblings, typical siblings can sometimes feel neglected or confused. How do we talk to those siblings? What do we say to those siblings? Spouses who feel more like they're in a parental role or a caretaker role than in a spousal role. And this is something that absolutely is experienced by loved ones and spouses of individuals living with this disease. Peer interaction challenges exist as well. And so certainly we think about this just even in terms of young children. Young children who might not be able to participate in the same things that their buddies are doing, whether it's sports, whether it's recess at school, that they're a little bit different than their peers. Sometimes the physical limitations make it hard to do these things that our typical peers are doing. As we age, not only is it those physical limitations and feeling physically different than our peers, but there's also just feeling socially isolated, potentially feeling like maybe folks aren't inviting you to something because they're not sure if you're going to physically be able to manage it. Childhood and adolescence, and especially adolescence, being different is really, 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 really hard. But we experience this as adults as well. It is hard to be different. And even the most confident adult can still struggle with that. So we've talked about psychological challenges. We've talked about peer, family, social interaction challenges. The last thing that I'm going to mention just really briefly is educational and occupational challenges. And so for those who are children who are living with RYR1 or parents who are taking care of children living with RYR1, I'm sure you could speak for quite a while about the need for different accommodations at school. And depending on where you live, what your school district is like, what the laws are in the country that you live in, sometimes this can be more challenging. Sometimes you feel like you're the one that is really having to fight for and advocate for these accommodations for your child, which is incredibly stressful. And frankly, stressful for the child who has to have the accommodations as well. Fatigue, just general fatigue, limitations that are occupational limitations, let me say, as we age. As we get older, as we're out of the school system, as accommodations are maybe not legally provided to us, and we are entering the work world, unfortunately, not everybody understands that individuals who are affected have different needs, have a shorter time that they are able to participate in certain things, medical appointments that they need to attend, so on and so forth. And so these are challenges as well. Concluding thoughts are that RYR1 affects more than just muscles. It impacts every facet of a person's psychological and social life, and that's why I'm here today. I threw out a whole bunch of different thoughts and ideas and potential things that you all might be facing. The goal now is for us to, and I'm looking towards Lena to help me figure out how we're doing this. We're going to break out into groups to delve deeper into the experience that we have related to this.